address the selected agents of pulmonary value. These medications will be of particular use in your research project 1. The first disease we will address is alpha-1 antitrypsin deficiency, which is a genetic defect that accounts for approximately 2% of emphysema cases in the United States. Symptoms of emphysema usually become evident in patients aged 30 to 50 years old and is manifested by lower lung zone involvement and can be greatly accelerated by cigarette smoking. Indications for drug therapy are symptoms of pulmonary emphysema not related to cigarette smoking and with measured low levels of alpha proteinase inhibitors or API. Medications include Aralast, Prolastin, Zimera, and Glycia, and with each of them, although they can prevent future damage, they cannot reverse current damage or improve lung function. They are also extremely expensive, costing anywhere from $25,000 to $40,000 per year. Since each of the replacement medications just listed are derived from human plasma, there is always a chance of communicable disease. Patients may also experience fever, exacerbation of symptoms, or flu-like symptoms. Patients on long-term therapy should receive PFTs to assess degree of airway obstruction and be monitored for their overall pulmonary health, including frequency of infections, cough, sputum production, and number of hospitalizations, and of course smoking status and smoking cessation therapy if indicated. The next topic of interest is smoking cessation medications. The initial goal of therapy is to replace the addictive nicotine that occurs in tobacco products and slowly withdraw the patient from tobacco use. As we know, tobacco use is the #1 preventable cause of lung and cardiovascular disease. The difficulty of withdrawing from nicotine cannot be overstated. Symptoms include cravings for nicotine, nervousness, irritability, anxiety or drowsiness, sleep disturbances, impaired concentration, and increased appetite or weight gain. All smoking cessation medications should be part of a comprehensive smoking cessation program, which includes counseling, behavior modification, etc. Smokers with signs of the strongest dependence on nicotine benefit the most. Signs of strong physical addiction to nicotine include smokers that smoke more than 15 cigarettes per day, prefer brands with greater than 0.9 milligrams of nicotine, inhale the smoke frequently and deeply, smoke within 30 minutes of rising, and have trouble giving up that first cigarette, smoke when ill, and have difficulty in smoke-free environments. Medications that may help with smoking cessation are nicotine polyacrylics, such as Nicorette gum or Commit lozenges, or Nicotrol nasal spray and inhalers, nicotine transdermal systems, which are patches applied to the skin and provide reduced nicotine releases over time, bupropion or Zyban, which is an antidepressant found in Wellbutrin. Although its exact mechanism is unknown, it is thought to improve mood and emotional state, making it easier for patients to stop smoking. Varenicline or Chantix, which inhibits the receptor for nicotine alpha-4 beta-2 nicotinic acetylcholine receptor. It is administered over a 12-week period and produces a 39% quit rate after 12 weeks. In all smoking cessation products, the respiratory therapist should monitor abstinence rates, look for symptoms of overdose, assess for weight gain, and provide counseling support. The last medication we will discuss is nitric oxide and its role in treating persistent pulmonary hypertension in newborns, or PPHN, and its investigational treatment in ARDS and pulmonary hypertension hypoxemia after lung transplant. Nitric oxide, NO, works by dilating the pulmonary vasculature to distribute blood flow to areas of better ventilation, which leads to increased PaO2. Since NO binds to hemoglobin, the systemic vasculature does not experience this vasodilation, and patients with normal pulmonary hemodynamics will experience no effect from NO. Special consideration should be paid to potential for toxicity, as it can form methemoglobin, which can cause severe lung injury, or if given with higher concentrations of oxygen, can form NO2, which causes pulmonary edema and can be fatal. Some of the medications used to treat pulmonary hypertension are the following: iloprost, or Ventavus, which is a synthetic inhaled prostacyclin and is used for treatment of pulmonary hypertension in patients with New York Heart Association, or NYHA Class 3 or 4 symptoms. These include considerable exercise and walking intolerance. Ventavus has been shown to improve both and is only indicated for patients older than 18 years of age. It is only delivered with special aerosol delivery systems called the NM Adaptive Aerosol Delivery System or the Prodosed AAD system. The last drug we will discuss for pulmonary hypertension is treprostinil, which is Tyvaso, which is also an inhaled prostacyclin vasodilator and is administered with an ultrasonic pulse delivery system called the Tyvaso inhalation system. It also improves symptoms in patients with NYHA Class 3 symptoms, which is only used for adults. Lastly, all inhaled prostacyclins should not be mixed with other agents, may cause bronchospasm, and have not been studied in patients with underlying respiratory disease.